A very good morning to everyone. And I should say morning for me, but afternoon for many others, evening, and even midnight or past that for some colleagues, because we have a truly international and global audience and global lineup of speakers today for the first in a series of podcast style webinars uh, put on by the Global Consortium for Innovation and Engineering and Medicine. We are so delighted to have participants joining us from healthcare, academia, industry, and of course, government. Our goal today is actually very simple. We are hoping to create a forum where leaders from around the world can discuss opportunities and challenges that will shape the future of healthcare, in particular with a lens on innovation and engineering within healthcare and medicine. So, for today, to kick off our conversation, we are thrilled to focus on big data in healthcare and how industry, academic, and government collaborations, what the role is of those, and how we can all work together to ensure we have access to and are benefiting from what is generally called big data in healthcare. Now, why did we choose this topic today? The reason why we chose it is the next step here. Everyone is of course talking about artificial intelligence and healthcare, and it's of course grabbed the whole world's attention. Some people believe that artificial intelligence will change the world the way electricity changed the world, and if that's going to be true, well, then we all know that artificial intelligence is only as good as the data that feeds these AI models. And truly, no one country or certainly not one institution can really drive the kind of diverse data we need to ensure that we are able to benefit from the wonders of artificial intelligence. And therefore, we thought that today we would use, since this is such an important global equity concept, that we would start the GCIEM's first webinar series with a focus on big data. Now, just a little bit about the Global Consortium for Innovation and Engineering in Medicine. It is an incredible vision that has brought together colleagues from more than 75 institutions across the world. Literally, almost all the continents are involved. That's why we have this global webinar spanning so many time zones. And what the consortium has been doing over the past 2 years is bringing colleagues together to really discuss these kinds of large, important concepts. And with me today are three very senior leaders in their own right. And after conversations with these three leaders in sort of a podcast style arrangement, we will then have some colleagues who are leaders in the global consortium who will then take the stage and discuss or reflect on the discussion that had just occurred. So to begin, let me first, of course, introduce myself. My name is Adil Heather. I'm a trauma surgeon, and I'm the Chief AI Officer at the Carle, Illinois College of Medicine in Champaign-Urbana in Illinois, United States. And our first panelists are from around the world. First, we have Dr. Ran, or he goes by Ron, Dr. Ron Balasier from Israel. We have Dr. Rajendra Pratap Gupta from India. And then we also have Dr. and Professor Deepak Kalra from the United Kingdom. So I'll begin with Ron. Ron is from Israel, and he serves as the Chief Innovation Officer of Clalit Health Services, which is Israel's largest healthcare organization and is truly recognized internationally for its leadership in population health and using real world evidence, and now, in fact, using AI to improve healthcare. And it's had a huge impact on national policy. So, my question to you, Dr. Ron Balasier, is that, as Israel is often viewed as one of the world's leading examples of a learning healthcare system, where clinical data is continuously used to improve patient care. Tell us what you think in the last perhaps decade. what has been the single most important advance that you've had? What has been the biggest success that you've had to be able to use all of this health data? Uh, Ron?
So thank you, Adil. Deborah, it's a real pleasure and privilege to be in this wonderful forum and podcast style event. And so I would like to start by saying that data is always a means for an end. You can use it if you have a clear mind of what you are trying to transform, and then data, AI, and every other technological tool becomes a tool in this process. For us, I think the biggest success that we've had, if I had to choose one, would be our ability to transform care from reactive to proactive, preventive, and predictive. And the thought process behind this is that we have understood quite a while ago that we will not be able to sustain our healthcare system in the current way of providing care because we arrive at our patients too late when intervention is costly and painful and of low impact in many cases because the pathology has been entrenched. And if we want to make a true difference in healthy lifespan, we will need to come early and address many of the pathologies well early enough. So by taking
Sure.
all of the patient's data and melting it all together and identifying the future most likely scenarios to happen, we are now addressing our patients' need ahead of their complaints and bringing them into the clinic. Let me explain what that means.
Sure.
So suppose you went for your usual blood tests yesterday. The results came in the afternoon. The primary care physician has not seen them yet. The patient hasn't seen them yet, but they're already registered in the system. At Clalit, once that happens, algorithms identify that those blood tests suggest a change, for instance, in the renal function of that patient, and that two things are now in place, in motion, because of the fact that they might already have, now we know they have chronic kidney disease. One is that their overall risk for cardiovascular disease has just got high enough to cross a threshold to put them in a priority group for proactive intervention. And their primary care physician gets that. And the other thing is that we should change their diabetic medication from drug A to drug B, which is more appropriate for patients with chronic kidney disease stage 3 in this instance. So all of that happens overnight. A recommendation goes to the primary care physician, and the next morning he calls that patient and says, I want to change something in your care pattern. And a message, an SMS goes to that patient automatically to say, your physician had a discussion with our AI system and decided to change your care. This is not a theoretical construct. This happens at Clalit now 300,000 times every month for our 5 million patients. So this is kind of the mainstay of our care. And I think that this is driving a major transition in how we look at what primary care is and should look like in a preventive and proactive approach.
Now, just to follow up, Ron, on this, can you tell us, like, are these AI agents that do these analyses, or is it one large data? Like, how do you harness all this data across, these 5 million patients?
So it's basically an ensemble of different models that work together. Some of these things need to be done by predictive models. And as we know, there are many different ways to do predictions these days. I
Yeah.
have to say that, many of those things could have been done a decade and 2 decades ago using the amazing AI tool known as logistic regression. So no, seriously speaking, in
Yeah.
many instances, it's still to this day difficult when it comes to tabular data, there were so many things you could have done and are still being done. But we also do foundation models that allow us to have more modern ways of doing predictions. So that is one component. And
Mhm.
the other component that we need to remember is that when it comes to, for instance, prescriptive care recommendations, you might be a little more careful about using some of the LLM tools for these practices, and you might want to go to what is known as good old-fashioned AI, which
Yeah.
means basically a decision support system that is much more deterministic and much less stochastic in nature to allow you to provide the right advice to the patient at the right time. We find that a combination of all of these tools together, depending on the actual utility, is the most effective way to do this.
Thank you, Ron. So clearly, utility trumps advanced or advanced models. You're looking at what works and not worried about what's shiny and new, it seems like.
Exactly.
Thank you so much. We'll move on to Dr. Gupta. Dr. Gupta, you've been one of the architects of the largest digital health transformation in the world. Of course, with India serving over 1 billion people, it's just incredible what you've been able to achieve. But we'd love to learn from your perspective, what the rest of the world can learn. You also have embedded within India, of course, very, wealthy populations and, of course, very vulnerable populations. So tell us how you achieved it across this diverse group of people.
Firstly, I must thank the institution, then Dr. Debra and you for organizing this. I owe much of what I did to meetings like this.
Hmm.
A lot of people believe that, we are knowledgeable people. No, not actually. I mean, Deepak and I go a long way, more than 2 decades. We travel over the world, we picked up things. So when the time came for writing policy for this country, I wrote that we will set up a national health authority. We will launch the National Digital Health Mission. And under that, we will do all this. And I'm writing currently a book on what India did to achieve this kind of scale. In my sense, what is important for people to learn, I have also worked in the US boards. And I still remember a meeting where the health reforms advisor to President Barack Obama and the medical advisor to Barack Obama was in our board meeting. And he was saying, and this is 2007, by the way, that we still have not released the ACO guidelines. There are 700 products. And that got my head ringing. How can that happen? Your ACO rules are not, our products are out. So when I got to write, first I did was put policy in place.
Hmm.
Then was standards, regulations, and then came the product. So one thing we build an institution. So anyone who is trying to put digital health in, whether a small state or a large country, just remember policy precedes your institution and institution precedes the rest. If you build an institution, I had this big dilemma where there are too many medical institutions at national level and state level. And whether we should create a new institution, I said, no, I'm going to look at creating a new institution that will only handle digital health. And I look back in the last, I would say, 8, 10 years. I'm so happy that, we have delivered 900 million electronic health records from the eSanjeevani platform. We have done now close to more than 450 million teleconsultations. That's the world's largest teleconsultation network of the government of India. And there is more coming. So one thing that I say is, do not make it a project. Digital health cannot be a project. Integrate it in the health system, put an institution for it, put seasoned leaders to drive it. I mean, that's what I have learned in the process of ideating, putting as a policy, institution, and implementing. Have we done yet? Not really. I would still say we are like 15% of what the vision was. But I guess as we keep discussing over time and learning from other parts of the world, in next 5 years, I think we would have changed the way how you create an asset-light healthcare model, which delivers cares to the remotest parts of the world. It's not about a lower middle
Can you,
income country or a.
Dr. Can you explain what you mean by asset light?
Oh yeah. So today clinicians' time is expensive. If I want, and it's a huge country like Australia, like US, any country has the issue of geographical width and the clinical depth. You cannot match both. It's not going to happen. Specialists are expensive, so are GPs most parts of the world. So what you do is we created eSanjeevani. So anyone on a phone can actually get on a consultation with the doctor, get a prescription. It's an asset-light model. I have a doctor sitting in remote part now, but we have done added AI to it. So India has hundreds of dialects, not dozens, hundreds. 22 are official dialects. So someone talking in one state in UP to a doctor in Karnataka, which is a different dialect, that patient will talk in his dialect, a doctor will talk in their dialect, but they will hear their own dialect. So I
Oh,
think
wow.
it's an asset-light. It's an asset-light model. Doctor doesn't move, patient doesn't move, they still get the care. So I think the world is moving towards asset-light aggregator models. And India has been able to show through COVID, we have done 2.2 billion vaccination, no paperwork. I mean, I'm incredibly proud of what we have delivered. Same we did with the digital payment interface. We put the digital public infrastructure and everything has, kind of been rolling on this. So I think
Well, that's
I'll wait for
incredible.
my book. Yeah.
Well, and from what I understand, there are more than 700 million smartphone users in India.
Yeah, there could be more actually. I mean, I have 3 phones lying on my table. Nevertheless, that the data is so cheap. It's the cheapest in the world and probably fastest. Now you're having 5G. So data is free. You make calls, I mean, literally free, I mean, if you ask me, so, and you make calls, they're not charged. You disrupted the entire financial model, so everything rides on data.
So coming to
So
the big data concept here, it seems to me that by focusing on the, millions of consumers and the thing that they had, which of course is an industry thing that is pushing, right? Like it's cell phone companies that are pushing all those cell phones out there. You benefited from this sort of leveraging what industry had already made people buy, so to speak, for health data to help for healthcare. So it's a very innovative model from that standpoint.
So I think, as rightly is the topic of this discussion is, the academia, industry, and the government. So I think all worked in tandem. So the cell phone companies put the towers, they got the high-speed data rolled in. Government said, we want high-speed data. Internet got in. So government moved with that speed, saying, I want all these things because we are making digital India. So I think at the same time, government had piloted the universal payment interface, UPI. You can make payments without being charged. Like credit card would charge you money. We don't charge them in India. We do billions of payments every month. So I think asset light model and government. See, this is where I think our discussion should, given that fact that we are moving in a world of AI and have been looking at it. I keep saying either AI will become expensive or the companies providing AI will become cheap. That's the only way it's going there right now. It's, unless government steps in to say it's digital public infrastructure.
Yeah.
Governments have a decisive role in the way humanity will move forward with digital tools. So I'll stop here. I know
Yeah, that's
we
a
went beyond.
really important point about what you said about the political will to say that this is public infrastructure. Speaking of public infrastructure and a country which of course has really led the way with the NHS, we have Professor Deepak Kalra from the United Kingdom, who's truly recognized internationally for your pioneering work in health data, especially interoperability and how electronic health records talk to one another, the governance frameworks around them, and so on.
Mhm.
So based on that, Professor Kalra, and based on your really career that helped define standards that allow health information to move back and forth, could you tell us a little bit about what you learned in developing these interoperability frameworks, and is this going to be a barrier or is this going to be the key to innovation and bringing all this health data together?
Well, thank you. That's a great question. And of course, it's a really enjoyable panel to be in. Thank you. I think it's going to be one of the critical keys, but not the only one. We need interoperability even more year on year because we are needing to connect more and more data dots to deal with the aspirations we have for health data. We want to better deliver and optimize complex multi-agency care to individuals, to personalized medicine, personalized prevention. We heard from Ran about that. We also need to be doing a lot with regard to clinical research and public health monitoring, digital transformation. You heard from Agenda are critical to have the data for all of that. And of course, AI development, which was how you started this session. But we can't connect these multiple and expanding number of data dots without interoperability standards. Yeah. But I would like to say that when I'm in meetings and discussions and reading documents about interoperability, I find there is still too much emphasis on technical interoperability standards and the silver bullet that they will solve the problems. Firstly, I would say adoption, actual uptake of interoperability standards, even old ones that have been around for a long time, is still disappointing. Many systems still don't talk a standards language, but we underemphasize the importance of semantics, of making sure that we protect and preserve clinical meaning when information is moved around. Remember that if you're going to use an interoperability standard, you're mapping from the source system to the standard. And then at the other end, you're mapping from the standard into the system of the local receiver, two sets of mappings, each of which could easily introduce errors. And that means that we have a real challenge as we plug in interoperability to focus on the trustworthiness of the data, its scientific and clinical reliability. Are we making sure that when data is being observed and actioned on by people who've received it from elsewhere, that they are getting a truthful picture of what the original data actually communicated to its authors and with its authors. To me, that's the holy grail we've got to still work on. So the job is not done. We don't just need to adopt interoperability standards as a plugin. We need to properly embed the use of standards with the systems that capture and communicate the data.
Deepak, is fire the end all be all for everything, and should all
The
countries
net,
be
do
on
you mean,
fire?
is it the silver bullet?
Yeah.
No, it's a bullet in the collection of bullets. And I don't mean to undermine the value of fire, but it is an example of the silver bullet conversations I hear, as if to say, if we can only map all our data to fire, the problems are solved. And I would say, yes, some problems are solved, but others that I've described are not solved. And the other topic I've not raised, but would now like to bring in, is the quality of that data. To what extent is the data captured and properly reflecting the truth of the clinician-patient perspective? Does the EHR system well enable the busy clinician, and in future increasingly the patient, to put into the record the right information with the correct balance of structures and codes that reflect the real reality? Is there completeness? Is there timeliness? Is there accuracy in the data? We're going to place an increasing number of tools, including AI. We've heard from you,
Yeah.
all of you, about AI. Machines are going to learn on the data. Machines, being as they are, lacking in all common sense unless they've learned common sense. So are we going to be feeding them with data that introduces and even amplifies bias and distortion, leading to misrepresentation of the advice to clinicians and the advice to patients? I'm really concerned that we need to focus on the quality of the data. And I find that when I speak to ministries at their ambition for data strategies and data quality and data and so on, they really focus on, HL7 fire is going to solve our problems. It doesn't improve the quality of the data. It doesn't make it more reliable. It doesn't make sure the context is properly represented. So I think, yes, you're right to raise it as an example of one of the successful resources to use. But please don't assume any one of these is just going to magically transform the landscape.
Well, I think that's so important that you mentioned that it's really the base of where the data is coming from that leads to this. And no matter how well we develop the interoperability standards. But let me just now, we have the three of you here on the panel, and just for folks who are joining in now, you'll see that we're having a wonderful conversation with Ron, Pradeep, and Deepak. And then after that, in the next maybe 10 minutes or so, we're going to transition to reflections from some of our GCIM leaders. And you see Dr. Yang and Dr. Riaju and Dr. Young, they're ready to discuss those. But before that, let me just come back to each of you for some additional questions. Ron, you heard about interoperability standards. You heard about how in India they were able to get hundreds of millions of people using their smartphones, and what Pradeep said about asset-light technology. Can you tell us a little bit about what is the right way to scale, especially to get to what you've discussed in your 5 million population, to take data and then actually make clinical decisions overnight? So how do we do this rapid innovation but still maintain public trust in the data and how these things are being processed?
Thank you. I think that's an non-solved question, but I'll try to give a few ideas about what can be done. First, there's no reason to assume that a solution that was developed in one point is going to be effective out of the box in a different setting. This is very different than what we're used to in medicine when we talk about medications, okay? You have a medication that's developed in one country, FDA says it's good. From that point on, you can use it anywhere around the globe with a high level of trust that it will probably be having the same effect to every human body that it encounters. It is very different for IT systems, for predictive, for AI. when you are trying to move and transition from one system to another, everything changes. The substrate changes. It is not the same data set. It is not the same population. There's no reason to assume it will work well out of the box. So it leaves a huge burden of responsibility on the organizations, the receptive organizations, to have a proper governance scheme on how to introduce new tools and how to assess both monitoring and evaluation of their effectiveness in the respective population. So I think the organizational readiness in order to both adopt, which is critical. Nobody can create all of the tools on their own, but also be very attentive to the potential drawbacks of getting tools out of the box and putting them in. So organizations that will be putting the infrastructure and the human resources required to do this assessment will be leading in introducing effectively these types of tools for massive use. So this is on the governance level. And I would say that everything that was mentioned by my colleagues before me is critical, mission critical for this. If you don't trust your data, don't put a fancy AI tool to try to use that in order to improve patient care. You are up to a very, very painful awakening once you will do your first assessment. So you need to go for step by step. Make sure that the data is appropriate, that the connectivity, we talked about interoperability, should be working, and then verify. And only then you might get the outcomes that you want on a population level.
Ron, let me just sort of dive in a little bit deeper here. You've discussed how you were able to build these systems that use data and are able to respond very quickly. But if you go back to, let me take you back to 2023, so barely 2 years ago, and the first models for ChatGPT came out, and they basically gave them to the world for everybody to use. No government oversight, right? Just go use them. And we had a lot of hallucinations, a lot of things. But then look how fast those, look where we were with ChatGPT 1, 2, 3, and now where we are with 5.5. Or, I mean, you talk about Anthropic's models, Claude, what it can do on a daily basis, even Gemini and all the rest. Uh, there was very limited government oversight, if you think about it, on how publics around the world got involved with this data, and that led to such rapid innovation. Is there a model that we can use in healthcare? In healthcare, we have to remain so conservative because, of course, lives are at risk. How do you marry the two?
So it's interesting that you ask. What we have done because of the 20-something years that we've been involved in putting AI into practice at scale is understand that we need to create a systematic model for assessment and development of AI tools that might be doing responsible AI in practice. We've created a tool called Optica. It's a framework of basically a checklist, like like they do in the airports to make sure that the flight is going to be safe. It's a set of checklist items that allow every organization to understand what they need to make sure before they go ahead, assess, implement, monitor. It was published in the New England Journal of Medicine AI, and it is free for use for all. So anybody who wants to make their respective healthcare system be, let's say, future-proof or ready to introduction and to use it, can actually download it and use it freely. And for us, we do not allow any AI tool to come into our organization without going through the checklist and knowing where we're standing. And so now this has become part of the national regulation and our own regulation, et cetera. But as you say, there's a vacuum in terms of the regulatory guidance that we get when it comes to this. So I'm afraid at this point, every organization on their own need to make sure that they have the governance system that allows them to move fast, but very, very carefully.
Well, to borrow an old adage, why should we have to recreate the wheel? If you've already developed this, we definitely should do it. And what I'm going to try to do is to find that, or maybe you can share it with us, and we'll definitely put that up on the GCIEM, LinkedIn and other social media, so more people can for sure see us. I'm sure the alt metric on that is through the roof. I can't wait to use it. Moving on to Dr. Gupta here, you just heard Ron's comments about how governments have been able to use it and a checklist approach, which seems like, for healthcare, we've seen all the way back to Atul Gawande and Peter Provost, how they were able to introduce checklists, especially in the operating room. I'm a surgeon and we use that on a daily basis. Could you tell us how you were able to do this so successfully again in India? And what is the right model for partnerships between the government and, of course, academia, very importantly, but then, of course, industry that gets it to people faster than any of us?
The secret sauce is very simple. Leaders don't understand what we are talking, and we get our way. Simply put, they didn't know about what we were talking, what digital health was. They were least interested. They wanted to win. And I must credit the Prime Minister for giving a free hand to just write the policy, my health minister. They didn't get it. I got in there. The only thing that requires is someone who understands the broader ecosystem. I had a challenge when I was writing digital health. They just told me, sir, just write IEC. I said, what is that? I said, sorry, I have to write to qualify what it is. Cloud, wearables, IoT, so that you don't mess up after I write the policy. So I think first understanding the domain is very important. If you know the domain, you can drill down to what you do. Government's job is to be selectively blind. I have to make sure that the industry innovates. I have a sandbox approach, but I don't strangulate with over-regulating it. So I think this is the fine balance you follow, is keep a close tab, but don't put your hand on it. So I would say that it's a fine balance, and someone who understands this can only handle in the government. It cannot be a well educated regulator who comes and wants to say, like Ronald Reagan used to say, anything that moves, tax it. If it stops moving, subsidize it. That's not what we have to do. AI is something every month the new model is coming. Tell me, how would you end up? You have to only put those checks and balances, as Ron is saying, that's the only way. But how good they are, it will depend on I keep saying, the quality and the liability of AI will not get decided by your regulation. It will be the first legal battle that big tech faces. Once that gets decided, then you will get to see what comes out. So I think we are still in that gray zone, and I'm thankful that AI is progressing in the right direction for now, whatever minuses it has. So I keep saying, put people on the top, put data beneath. That's the only way you have ethics in this. People have to be at the top. You cannot put just that. And, Deepak guide on data AI first later campaign. So data has to be something that you have to be very, very careful. Integrity of data, integration of data, intelligence next. We put intelligence first. That's our challenge.
Well, I think, you mentioned how the most senior leadership of India, trusted. So I'll use that since you referred to Ronald Reagan. My favorite quote has been, trust but verify. And I think
that's the US $100. I think you are chasing the money, which is good.
Right. Yeah,
which is good.
But of course, it's from your standpoint, I think it's important to note the reason why senior leadership of any country is able to trust people is because of their track record, seeing what they've been able to do. And I think having those kinds of that kind of track record, of course, Dr. Gupta must have made a difference. So
I think the credibility of the policymakers is equally important as the credibility of AI.
So let me just move to, since Deepak, you have, of course, had a huge impact on the national health data strategy across the UK. And of course, the world looks towards the United Kingdom for especially, policy, procedure, formalities. Could you maybe discuss what are some pieces of advice that you would give to colleagues in this discussion who are trying to leverage or trying to lead and work with their governments on AI data or health data strategies?
Well, thank you. I think I would perhaps like to lift your question immediately to a multi-country perspective.
Sure.
Because I don't think that a single country is big enough. What we see, as we've seen with pharma, for example, which markets its products globally, the knowledge discovery, the governance, the quality assurance and trust all have to be handled at a multi-country level. And at least what I could say is that within Europe, including the UK, there is a general convergence towards a number of good practices that either legislation or regulation or policy are in various ways attempting to mediate. They are a little bit in the spirit of what Rajendra said. They are sort of providing external guardrails, not deeply controlling the detail, because that's not tenable. And it does include things like ensuring that the development of AI is properly risk assessed before you embark on it, that you make sure you use representative data and you assess the data to ensure that you know what biases exist. I don't mean that you can have bias-free data, but it should be low bias and you must know what they are and know how to limit your claims in order to be in keeping with the biases that you have underpinning your systems. But also, I'm going to shift from the developer to the adopter. There's an increasing expectation that those who adopt AI actually are trained in how to use it. And there's an increasing emphasis now on AI literacy education, that clinicians, that managers, procurers of systems understand AI well enough to know what the strengths and weaknesses are of an AI-based solution versus a non-AI solution, how to make sure it is used on the right patients at the right points in the care pathway. Something that I think still needs a lot more effort is helping clinicians to understand when they should be skeptical and distrust an AI recommendation. That may not be because it's badly developed. It may be because the underlying patient record isn't as complete as it could ideally be, and the AI is itself being misled by some of the data that it's receiving about a single patient. So how do you detect and override AI? When does the human in the loop exercise their humanness? What kind of human is needed? What skills are needed? Can we now mass de-skill the health workforce and say, just become AI actors, no longer thinkers, no longer smart? Let the AI be smart, you be dumb. Is this where we're going? No, not at all. So I think there are a huge number of things that are still being articulated, still being shared. And we also work as an institute quite nicely with the OECD, which is developing international guardrails and good practices on AI development to influence policy. I think you can develop good practices for the developers and the adopters without over-imposing on the field, because it's innovative. We have to allow it to breathe. We can't over-restrict it. We can't be too prescriptive. But a wild west of AI is also very dangerous, and over-trusting it as well. So let's find that balance.
Well, thank you so much for that. And those are such important comments. And we're lucky to have the two of our GCIEM leaders, along with Dr. Young, to kind of reflect on what you've just discussed. And my first question will be to Dr. Luana Ariaju from Brazil. And I know both of us had the privilege of doing our public health degrees at Johns Hopkins. But what I know is that you were also one of the first Solmar scholars there. And during COVID, at least the first time I saw it was when you were doing really good communication around COVID and so on. So, if you had to communicate what you just heard today from the three scholars above, what would be the take-home message in your mind, and where do you think we need to go with health data?
Hello, everyone. Hi, Edo. Thank you so much for having me here. It's a pleasure. I think that this discussion has been quite interesting and quite enlightening, because it shows that we share, um, al- although we come from different environments, we definitely share the same problems, the same issues. We are talking about quality data. We are talking about trust. We are talking about ensuring that the consequences of the proper use of AI are actually the one that we want, and not as something that we cannot control or that is actually damaged. So I think that one of the most important things that we have learned here at Einstein, here in Brazil, and I think that resonates a lot with what all you were saying, is that our biggest challenge is not exactly making AI work in a broader sense. It's to make AI work in the real world.
Yeah.
And real world is heterogeneous everywhere, right? Even if you're talking about high income countries, they encompass enormous variations in demographic, socioeconomic conditions, environmental exposures, healthcare access, disease patterns, and not even to mention the quality of data. So if our data fails to capture that complexity. Our models may perform well on average, but we don't treat average, right?
Yeah. Yeah.
They may fail precisely where better decisions are most needed. So I
Yeah.
think that that's our issue, and this is something that I think that Latin America can actually contribute a lot. Not because we have, not because we represent diverse populations, but because we have developed science and public health in environments where biological, environmental, social, and health system factors interact continuously. So I think that complexity forced us to think beyond isolated data sets and towards integrated systems of knowledge.
Yeah.
So I think that we can summarize what we have heard today, and I can relate to that as a representative from Brazil, is that I think that we should not be concentrating, and Latin America should not actually be viewed simply as a source of diverse data.
Yeah.
We should view everything, and especially Latin America here, as a source of scientific insight into how health systems function under complexity. And this is, I think, that we have a consensus here, right? We are not talking about simply integrating good quality data or integrating data sets. We are talking about how can we implement that in the real world with all its complexity. So for me, it's been a real pleasure to hear all of you.
Well, thank you so much. And again, just to note, I mean, the diversity of experience that we had here, we've heard from colleagues from Israel, India, the UK, and of course, Latin America. And thank you for pointing out how Latin America's data should not be thought of as, okay, let's bring them in for diversity, but actually, let's actually look to how Latin America is doing this. And it's of course, large, diverse, group of fantastic people who we can learn a lot from. So thank you for making that specific point. Now we've been all around the world, but let's go to Asia and Taiwan with Professor Albert Yang. And Dr. Yang is and not only one of the major leaders of the Global Consortium for Innovation in Engineering and Medicine, but he's leading the effort of the organization to put together a billion-person data set, as they like to call it. So, Dr. Yang, maybe you could tell us a little bit about the efforts that the GCIEM is doing, and then we'd love to get your reflections on the conversation. But I really would love for you to give a little bit of context of what the GCIEM is doing.
Yeah, thanks, Ado. It's really nice to be here, and thank you for having me. So I think one of the major, tasks for the GCIEM is try to make the data available across the border of the countries, because I think the panelists here already shows that it's very important to not only to get the quality of the data, but also the diversity of the data, because the bias of the AI model would just endanger the use, the use of AI in the clinical practice. So I think the GCIEM really wants to build a data warehouse that not only benefit our member institutions, but I think by collecting the data from the different countries and different institutions from different parts of the world, that can make the specific data sets that is without the bias, and also ensure the quality of the data harmonization, and also to make the AI model more reliable. So I think we are doing this right now since 1 year ago. And I think for this year's Global Summit, we already showed that it's possible to build infrastructures to host the data from different countries. And now I think we are trying to do the pilot project to begin to collect the data from different countries. That will be very interesting. Yeah.
Well, and I know we still have Dr. Kalra here, and I know Ron was there as well. Love to get your perspective on, if we're going to build these large data sets, and this is not just about interoperability, but about trust. I mean, how do we build it where we're able to create a data set that would be from Brazil and the UK and Taiwan and Israel? How do you go about doing that? How do you develop the trust? How do you create the governance model? Deepak, what do you think?
Well, I think it's probably fair to say that a very large number of national big data projects have actually failed
Hmm.
to win public trust. And a number of those that I'm familiar with have had at some point to go backwards. And they've either gone backwards by downscaling hugely to a much narrower scope, or worse, they've been killed because of public outcry and left a period of time where the public is so untrusting that a few years have had to go by before a new initiative can be tried because the public were too negative. So actually, we have the potential to do a huge amount of harm to the endeavor unless we're careful. And what we need to recognize is that there is an inherent lack of public trust in big organizations, public and private. I mean, which public is in love with their governments? Not that many, if I'm honest. And then there is a distrust, perhaps also of big industry, not necessarily deservedly so, but it's there and let's accept it. I think the other problem, though, is that very, very few times when data is used for public good does anybody learn about it. We have collectively, as a multi-stakeholder global community, if I could use the word community to collect us all together, we have been lousy at communicating to the public when some data use has given rise to an innovation, an invention, a better care delivery scenario. We might talk about the scenario, the innovation. Yes, of course, that's exciting. I mean, even as I read on every few days, I read about a new breakthrough, dementia or something. Where in the article does it say, 250,000, 8.4 million patient records were examined as part of this process? Do you ever see, thank you, Manchester, for all of your diabetic data. We've done a huge amount. But no, none of that. So we're not going to win public trust if the public don't understand the benefits and the value with a track record, not hypothetical one day in the future, but already there have been benefits that we've not sung. But that has to be partnered by confidence that we intend to safeguard you and your data really carefully. How?
Yeah.
Does the public have good literacy on information security? No.
Yeah.
Do we help them? Who knows what anonymization means? Very
Yeah.
few people out there, etc., etc. And the final message, the vulnerability to misinformation has never been worse.
Luana, let me move this to you, given your
Yeah.
experience in science communication. What do you think? And first of all, the data we have to be good with the data, right? We have to
Mhm.
be doing the right things to win the trust. But love to hear your perspective on this.
I'm just listening to Deepak and thinking, oh, this is such a nightmare because this is a transversal issue, right? It's not only about data. It's about, trust is built for sure after a transparency and
Yeah,
small
yeah.
successes that needs to be easily perceived by the population. So we talk about grandiosity, but what people needs to understand, what they need to understand is that that specific thing that you just mentioned actually made a difference in that day.
Hmm.
Especially when you're talking about this heterogeneity that we mentioned, low middle income countries where I come from, people have a much more urgent needs. They need to put food in their mouths that day in their families. They need to ensure that their kids are in school. So when we are talking about these um, a bit far from reality uh, points that we make when we are talking about data and everything in this matter, it doesn't appeal to people. So we need to know how to, and please take me in the right way when I say this. We need to seduce people with
Mm-hmm.
transparency and okay, it's like almost like a make data sexy again or something like this.
Make data sexy again.
We need to alert in that sense, and we are failing to do that in a number of situations. I think that COVID presented that in a very opulent matter to all of us. we fail. We know how to communicate to each other in academia
Yeah.
or in industry or so, but we are failing to communicate with people. So I have the opportunity to be part of the first ever commission of Nature Medicine, and we focus on quality health information. So everything that we are talking here for sure has also a root in this problem. And this is something, for example, that I think that we should work on together. We are talking about integrating data sets. We are talking about learning from each other. But I think that the capability that we need to develop is adaptive intelligence. So we need to maybe find a common, a shared problem, something that we can only address together with our complementary capabilities. And maybe with that, we can learn to continuously observe, change, generate, share understanding, coordinate across institutions. And I think that by doing that, we develop much more than the isolated capabilities that we are talking about. And by doing that, we also can move more people around the issue that we are talking about. So I think that our challenge, more than communication itself, like what to say and how that should be perceived, is transforming the technology that we are mentioning into coordinated action that again can be perceived by common people. Then we can maybe earn that trust and the allowance to go further. We cannot go further without that. This is how I feel.
So what does that come to? MDSA, make data sexy again? Or and
Trust me, I don't like to quote that specific persona, but I think in that sense that may be useful.
so I mean, if you find it on LinkedIn in a few hours, you know where that came from. So uh, let me move to and I'm so glad, Ron, you're back there. I'll come to you in a second, but I wanted to just get Dr. Yang's perspective here on what's being discussed, but also some of the practical challenges with bringing data from so many different countries. And you're of course doing a lot to de-identify it and so on. Tell us what you're doing to get over some of these challenges, and what can we see from the GCIEM's future data warehouse
Yeah,
or data
I
warehouse. It's
think,
already there. Sorry, that's what I meant.
okay. So I think that the great challenge for the data warehouse for GCIEM is that how to protect patient privacy.
Mm.
So everybody knows that we already experienced lots of the data breach in the past years. And the most recent one is UK Biobank. But UK Biobank doesn't the data breach doesn't happen because the real data has been leaked. It was because the data was downloaded from the UK Biobank and sold to the other parties. So there are lots of the different kind of data breach, but I think to protect patient privacy is really one important challenge that we need to overcome when we build a data warehouse. And how we do this is, I think one possible solution is that it is kind of synthetic data. So using the generative AI, the power of the ability of AI to learn the features from a large population or large cohorts of the data can actually mimic or synthesize another set of data that cannot be traced back, but also can be useful for the research. I know this sounds like science fiction, but I think is really we need to use the power of AI to not only to build a better clinical applications, but also to protect the patient privacy. So I think that's the way we want to do in the GCIE and to make the data available to member institutions. Yeah.
Well, that's super important, and thank you for sharing that and the vision of the GCIM. Ron, you've heard a little bit about making data sexy again. I'm going to go with that one, Luana. But tell us a little bit more about what you think in your kind of closing comments here, Ron, about what we should be doing moving forward.
So first, I want to say that for some of us, I think data has always been sexy. So I think We're in a good shape. But seriously speaking, I think that one of the things, and this really plays well with the topic of this discussion, we need to have better international collaborative efforts to try to create the evidence, communicate the evidence. You know, there's been a recent publication that show us the evidence. There's so much hype and so little well-crafted evidence to suggest the positive impact of these efforts on human life in actual, measurable, meaningful outcomes of interest. And I think that we should be able, as a group, to be able to show, one, to suggest that the impact is real, and two, that transfer learning and moving tools from one system to another is feasible, meaningful, and helpful. And there are very few examples of how this is being done correctly. And I think different consortia, and the one we're talking about here, can also play a role there in being able to create this evidence, communicate this evidence, would be a very meaningful contribution to the global efforts in this domain. So this is more of a call for action to end this important webinar. And I think this is something that we can do as a group.
Well, thank you so much again for all your time today. We learned so many important comments, and if I had to distill three of them, the first is to see from the example that Ron gave on how they're able to really use a learning health system to bring in data, process it, and that you don't need to have the most fancy foundational models. 20-year-old logistic regression also still works great. It's all about implementation and getting it to the patient. So that was my first thing that I thought was hugely powerful. The second thing was, and what was talked about that, there's no silver bullet as far as bringing all this data together. And it is going to be political will to figure out how we get all this data to work together. But thirdly, none of that's going to work unless we are able to create a trustworthy framework in which the public, our patients, who in the end, we are all at the service of our patients. In the end, it's all about them trusting the data and where it's coming from, and the algorithms and all those kinds of things that make that data lead to therapeutic support and decision support. All of that has to be trusted. Otherwise, this will not work well at all. So those are the three things I definitely got. I again want to thank our panelists, Ron, Deepak, and we still have Luana and Albert. Maybe just a 30-second comment to each one of you to close, and then we'll ask Dr. Young, our great organizer, to close us out. So first, Luana, 30 seconds.
I just want to thank you for the opportunity. I think it was an amazing time. I'm available to discuss whatever you want to. I mean, panelists and also our audience. I'm happy to be there. And I just want to say that I hope that the consortium can, in a year from now or something like this, to start small but start together. I think that if we can do this, I think it's a great achievement for our short-term future. Thank you so much.
That's wonderful. Albert?
Yes. So it's happy to to have this kind of symposium. I think it's really great to everyone work together to achieve a very difficult goal. Thank you.
Thank you so much. And again, huge thanks to the Global Consortium for Innovation in Engineering and Medicine. Again, another thanks to our president of the consortium, who's also the dean of the Carleton Illinois College of Medicine, Professor Mark Cohen, for the vision to bring all this together. And of course, Dr. Young, the associate dean, and of course, who's leading this effort on behalf of the consortium, with her great colleague, Alex Radcliffe, and others who've really done a great job. So over to you, Deb, to close us out.
Thank you so much, and thank you to our panelists. Everything that I heard today went back to some of the foundations of what I learned in my schooling, and that was really about collaboration and breaking down barriers. And in order to do this and do this well, it's not just barriers within our own institution, it's barriers from around the world. And I think you all here today are leaders in that space. And I definitely look forward to continuing to work with all of you and learn from all of you. And we'll continue these great discussions. I know that Ron provided me a couple of resources to share out with everybody, and we'll make sure we get those out to the consortium. And again, thank you so much.
Thank you, everybody. Have a great rest of your day or morning or evening. Good night.